Good morning, everyone, or I'm sorry, good afternoon at this point. I'm Dr. Trang. I am one of the third-year faculty development residents at Nellis. So I'm going to talk to you today about cognitive biases and what we can do about them. So to start off, does anybody in the room kind of define their understanding of cognitive biases? Yes, yes, sir. Dr. Kim, you're nodding your head. Oh, that's right. Yeah. Yes, this is an updated version of the talk I gave at Fort Belvoir for our morning report. So cognitive biases are basically thoughts that we have that cloud our actions, and in this case, our clinical reasoning in the medical setting. This is important for both faculty and residents and medical students, because this is what then leads to our actions with how we care for our patients in the future. Okay, so quick objectives. We'll basically talk about the problems with cognitive biases and how this affects our patients, how we can help learners. I did tweak this lecture, forgive me, med students. This is a little bit more geared towards faculty and how we approach cognitive biases, but this can still be applicable to you as well. Just through a different lens. And then lastly, to become familiar with different methods that maybe we weren't aware of, or re-emphasize the ones that we have available but maybe are underutilizing. Okay, so why is this important? So I'm not going to read all the numbers to you, but basically there's a good percentage of hospital admissions that have medical errors associated with them. And of those, about 70% of those are diagnostic errors. So those are errors on our part, not necessarily through the system itself. Okay, and essentially, we talked already about cognitive biases being an effect towards our clinical reasoning. And so if we don't acknowledge our cognitive biases, we then allow that to infiltrate our clinical reasoning and then thus affect our patients and cause more medical or diagnostic errors. And most importantly, on this rotation and in our particular setting, that says that clinical reasoning is the major goal of education, medical education. So our big job as faculty and as learners is to develop that clinical acumen and that clinical reasoning skill to best provide care for our patients. Our, I'd say, mission is to train competent physicians in all realms to be able to take care of our patients best. And if we ignore this big elephant in the room, we're not doing our best job. Okay. So these are some of the factors that can contribute to cognitive biases. So we are mainly going to focus on the cognitive factors, but patient factors are what the patient comes in with, whether that's their past medical history, whether that's their attitude, whether that's their social determinants of health. Those are things that we pay attention to, and we are including more in our discussion of caring for our patients and not just the diagnosis we see in front of us. And then we have systemic factors. So whether that means Alta or Centris or Genesis isn't working very well for us, or whether that is that our hospital system has an inherent flaw that we are trying to chip away at. All of those can contribute to our cognitive biases, but we'll focus on the cognitive factors that we hold in our own minds. Okay? And all of that then can lead to our diagnostic errors. So that's kind of re-emphasizing that foot stomp that this is really important to our practice. But first, we'll start off with a case. So if you're a medical student, imagine you're now an intern. And if you're faculty, imagine this is your intern that comes and presents to you in the middle of the night for an admission from the ED. The ED doc had told the intern that they have a 73-year-old male, metabolic syndrome, came in for shortness of breath and fatigue. And oh, by the way, 4 days ago was released from a 10-day hospital stay, was diagnosed and treated for diverticulitis with IV antibiotics. Okay? And the rest of the history that your astute intern or the medical student who did this admission tells you that their vital signs are normal, they're afebrile, but they felt warm. The ED doc told them that they felt a little warm, and so maybe they had a fever at some point. Normal exam otherwise, labs, maybe has a mild AKI, and lactate is 1.8. Not totally elevated, but creeping up there. And then on chest x-ray showed right middle lobe consolidations that were maybe concerning for a possible acute process, but correlate clinically. And the emergency department thought that they would want to be helpful and guide the intern and tell them what they thought. So they are diagnosing this patient with hospital-acquired pneumonia because, of course, he was recently diagnosed with diverticulitis, admitted for IV antibiotics, most recently within the past 3 months. So the ED decided to go ahead and start him on, there were different antibiotics in the past, but he was on, the most important part is that he's on now vancomycin and Zosyn. He was given a half a liter of fluids, and they did some cultures on him. And then they told the intern, it's your job to then, I'll leave it up to you which third agent you want to start on this patient. Okay, so off the bat, what kind of biases could you anticipate your learner kind of developing or having from that presentation? Yeah, continuing with the treatment. Good. Believing in the diagnosis that they were told. As med students, how would you feel if an ED doc told you, hey, this is what I think this patient has, and this is what I've already started? Would you feel inclined to push back and say, I don't think this is going on? And that's okay if you do or if you don't. There's no wrong answer. Probably not, okay? Right. Continuing with what he said to do. Good. All of these are variations of named cognitive biases. Yes, sir. Correct. Yes, so they are going with what's been told, and they think that that's already been done, so they don't need to do it. Good point. All righty. All great points. So to kind of translate those into more academic terms, the first cognitive bias that I would note is anchoring bias. In this case, latching on to that initial information that the ED doc gave them. So they're anchoring down on what's been told to them already and running with that particularly. So diagnostic momentum. So continuing with that. So a lot of these kind of blend together. I like to think of these cognitive biases not as individual discrete concepts, but as a spectrum, as a continuum. So you may see some overlap in anchoring and diagnostic momentum biases. So the ED's presumption that our patient is being readmitted for HAP, we continue with that, and our learners can continue with that, which is a track that may be because they've seen this before and they have maybe some cognitive kind of presumptions that the ED doc knows more because they are ranked higher, they have more experience, they've seen this tons of times. Who am I as a third or fourth year medical student to say that they're wrong if they've probably seen this much more than I have? This is my first time ever seeing anything similar to this case. And lastly, premature closure. Similar to what Dr. Ramey was saying, that they are accepting that this diagnosis, this exam, their data that they have collected are in fact and set in stone. And if they were to repeat it, it would be the same. So they kind of stop searching for a different problem or a different etiology. Okay, so how can we prevent this? So we do these things pretty well to the left. We already talked a lot about reflective practice within our the USU's curriculum. We discuss and we train our faculty to practice micro skills with our learners and 1-minute preceptors to make sure it's almost like a mental checklist of all the things that we want our learners to chug through to make sure they are hitting all of their milestones for their encounters. And then M&M meetings. So these we have incorporated into our culture to make sure that we have a way to open it up for discussion when maybe there is a medical error that's gone on, and we can hopefully identify some of those cognitive biases. But is that enough? So things that we could do better. We allow for more diagnostic timeouts. And that means during rounds, which takes some time, during presentations for admissions, forcing our learners to reflect a little bit more, take a couple minutes to develop that, broaden that differential, to discuss and have a back and forth conversation about what else could be going on. Sometimes we do this well, but it's not always a consistent practice, especially if there's 10 admissions rolling in from the ED or we have a full list on our service. Okay. Also, supporting discussion about it being exposed to these biases, or that exposes more biases than are on this list. So talks like this, maybe even talks at our morning reports, or even in their didactics, incorporating that language and normalizing the biases so that we think more about our own biases that we bring towards our patients. And then longitudinal curriculum in GME. I think that here at USUS, I've been very pleasantly surprised that this has been more on the forebrain. It's been more purposefully practiced here, but it's not so much in the GME realm. And I think that that's something that we can open up discussion for and press further for. And then lastly, training that illustrates biased thinking, whether this is just small group participation discussions, or ways that we can, just like we train with cases for diagnostic purposes, we can train for cases for biases purposes and help identify that a little more. So all this to say that there is literature out there that's building. It's early, but AMC, through their MedEd portal, has actually written a pretty good study about, and this one is specifically with psychiatry residents, but they have incorporated internal medicine, emergency medicine, and family medicine. So that's in the works, but this is just a snippet of how we can even do this in a short 1-hour session. And if I have resources on the resource tab, but they have it all lined out. They have their own workshop skills, the slides themselves, much probably more articulated than, or better articulated than my slides here. But the bottom line is it's out there. We don't have to recreate the wheel, and we can make it a lot easier for other programs to practice this as well and hopefully identify this. Oh, that's what I was gonna say. So I'm teaching this to the experts. But yes, it was a great resource that I found in my research on the topic. So thus in summary, cognitive biases can lead to major diagnostic errors. And we need to raise awareness and culture regarding the practices, changing these practices to make cognitive biases more of a normative discussion so that we're not penalizing people for having these cognitive biases, but more so discussing it so that once we say it out loud, we'll recognize what our biases are, and hopefully we don't translate those into practice unnecessarily. And then hopefully developing more formal curriculums. It sounds like USUS already started a very strong curriculum, but now translating that into the GME realm. Alrighty, these are my resources. Thank you. Questions, comments? Yes, sir. Great question. So that was actually a case when I was a senior on nights, and my astute intern did a very thorough physical exam. I actually left that slide out. I did talk about it at the morning report, but he ended up having heart failure with preserved ejection fraction. So good case. All righty. Thank you so much. Thank you. Good job.
All right. Can everyone hear me in the back again? Okay. Just making sure distance is good. So my name is Captain Carroll. I'm one of the faculty development residents also here, one of the PGY3s at Fort Belvoir, so right down the road. So just like the rest of us, we were asked to give a talk during the grand rounds, somewhat based on the talk that during the faculty development curriculum we give at Fort Belvoir already. And the one that I chose to give a brief re-review on is hypertension in older adults. And so without further ado, we can jump right into that. And so just really quick, who am I? My wife is on the left there. That's from graduating at COT, which seems like just yesterday, but it's not anymore. That's the dog we got when we were still in medical school to help Jessica just feel a little bit more comfortable. The cat that we adopted last year that actually has diabetes that we're treating with insulin, which is a really interesting thing that's been going on, and then my 2 kids. So diabetes in a cat is a thing. So the objectives today really are just one. So just review some recent literature on the hypertensive treatment in the elderly. One major study being by the STEP group for treatment of Chinese individuals with hypertension between the ages 60 and 80. So we'll get into that in just a minute. But before we go into that, one of the reasons why I brought this topic up during this talk is because this was a case that I presented at Fort Belvoir on Friday of last week that just had a lot of talking points about it, just because it's incredibly complicated to treat patients with these medical issues in this demographic. And so I just wrote this case myself, but it's an 83-year-old female. She has a history of high blood pressure, high cholesterol, chronic kidney disease, eczema, allergies, and a TIA. But then she's also had a couple of falls in the last year. And she comes in with a blood pressure of 153 and 92. And my question, quite plainly to the group, in the small groups that we had, and there are 3 groups of 4 each, was what is her blood pressure goal? And how would you manage this patient? As you can imagine, this case had a lot of things going into it with, this is what this guideline says for this blood pressure goal, but she has chronic kidney disease, which like she also had a TIA, but then she's been falling. So what do we do, right? And so these 2 guidelines that have come up, on the right here, we have the ACC/AHA in 2017. And then 6 months before that came out, we have the American College of Physicians, the American Association of Family Practice that came out. Same year, different recommendations. And so these were the 2 guidelines that folks in the small groups were quoting, not arguing about, but discussing back and forth. And so on the left side, right, we have in adults greater than 60, the treatment goal for them should be less than 150. But if they have high CVD risk, on the bottom here, it should be less than 140. And as you guys, medical students particularly, folks who are above the age of 60 just quite often have medical comorbidities, which increase their risk for cardiovascular disease. That's what CVD is. And so we often have this as being their blood pressure goal. So here, let's talk about that a lot. Less than 140 systolic. But then, as you can see here, right, this is a lot more aggressive. And so this is something that was brought up a lot because our patient from the case that we had some falls. And so we want to make sure that we're not over-treating her with some to lead to adverse events that we'll talk about. But they do have a caveat in this guideline that says, intensity decisions can be reasonably made based on clinical judgment, patient preferences, comorbidities, life expectancy, and risks and benefits. So part of medicine. So some recent studies that guide the management in this population. When I was looking into this in a couple of days that I had, I found a few that really were pushing the management. How we do this. The one that I found was actually called the HIVET trial, which was in 2008. It was published in the New England Journal of Medicine. And so what this looked at was about 4,000 very elderly patients. And this was actually one of the first studies of its kind looking at patients greater than the age of 80 in their cohort with hypertension. And what they found was in treating patients with hypertension with a diuretic and an ACE inhibitor in a stepwise fashion, depending on the ability to control their blood pressure, versus a placebo, they had reduced rates of fatal and non-fatal stroke, all-cause mortality, and cardiovascular outcomes. But the major problems with this study, though it has a really good N, is that the way that they reported their adverse events is that there were adverse events. That was it. And in addition to that, the pharmaceutical company that made the ACE inhibitor sponsored the trial. And so although this is not the best study to move forward with, it does show a couple things. One being, if you treat patients, they might do a little bit better. But then also, what are these adverse events? So fast forward a couple of years, we have the SPRINT trial, which you guys going through medical school, you hear all about the SPRINT trial, because it's all over the place. And they have a great number of patients. They have about 9,000 patients who are high risk for cardiovascular disease with no history of stroke or diabetes, which is important. And so what they wanted to test was if they have a patient cohort that they treat intensely to control their blood pressure with a goal of about 120 or lower, versus a standard treatment group, which the target is about 130 to 140. It resulted in higher improved cardiovascular mortality and death from any cause. And this is going to be important in the next study we talk about. But the problems with this is that there was a significant increase in hypotension, which goes back to the case that we talked about. Maybe that's why she's falling. hypotension, syncope, AKI, and electrolyte dysfunction. But there was no difference in stroke or ACS. And so their target, their primary outcome in the SPRINT trial was the first occurrence of something was their primary outcome. And the secondary outcome was just looking at everything else. So the trial was stopped after 3.3 years because they met their outcome relatively quickly. But they didn't have a difference in those two, and then they had some pretty significant adverse events. So this comes out, the ACC guidelines come out, the American College of Physicians and AFP guidelines come out, and then there was a lull for a couple of years that you guys will learn about, and then another guideline came out that said, everyone relax. The International Society for Hypertension released something that said, we still can do this, patients who are greater than 65, even though that one trial does say, and the ACC says, let's treat aggressively. For certain patients, we can still do the less than 140. We don't have to be that aggressive because we want to make sure that they can tolerate the medicine. Okay? And then our lovely Dr. Arnold was included in one of the AFP journals regarding this and the highlighting of that. But this is a really cool article in that, or a guideline, and rather, it targets low-income, middle-income, and high-income countries and has an essential versus optimal treatment pattern for hypertension, which is a really cool thing, which you can apply in multiple places. So the study I want to review is one that just came out in the New England Journal on the 30th of September. And the way that they designed this study was multi-center randomized in a controlled trial, and it was about almost the same number of patients as the SPRINT trial, had a really big N. And it was based in China. In the SPRINT trial, interestingly, did not have any Chinese patients in it. It was essentially half non-Hispanic blacks and then whites. And their other was about 2% of that 9,000. They didn't list any of that being Chinese. And this was almost all Chinese. About 90% were Han Chinese. We'll talk about that. And it's essentially the same thing, intense treatment arm and a standard treatment arm. And what their primary outcome was a composite of all of these things, so all the bad things. And their median follow-up was about the same because it was stopped early because they found there was some benefits. But I thought that was a problem. The patient needed to be able to participate in app-based follow-up in the care plan. So there's a caveat that also. The results, like I said, it was stopped early because they met their primary outcome. Okay? So it was a composite of them meeting some of those standards. And some of the ones they met specifically, they met statistical significance, were stroke and acute decompensated heart failure, as well as ACS. But they didn't find significance in cardiovascular causes or death from any cause. Okay. And then the renal outcomes did not differ significantly. So I bolded this and I bolded that because the SPRINT trial did the opposite, which I found was really interesting in that the SPRINT trial showed that there was a benefit in cardiovascular and death from any cause, but the only one that had a specific benefit was decompensated heart failure, right? So I thought that was very interesting. But some of the caveats were that the adverse events, hypotension was still a problem. Despite the fact that some of the benefits were flip-flopped, hypotension was still an issue, which did meet statistical significance. Syncope did not. And although this study does not represent the US demographics that we have, it hit a population that the SPRINT trial totally left out. And although it's not based in the United States, it still accounts for some patients that were left out in our studies. And then the other caveat that I found was really interesting, that they are going to publish in a separate article. They just did not include the data. And this article here is how this app affects the way that we manage patients' blood pressures, but also it very much selects for patients who are able to participate in that app to begin with. So we have to try to understand the generalizability of this study. And so after reading this and comparing it with the SPRINT trial and all the guidelines we have, I also have some takeaway points and questions. So we have multiple studies and we have a bunch of guidelines from those studies that are showing improvements in hypertension-related outcomes, but the outcomes themselves are inconsistent. And we haven't had a big meta-analysis, since for several years, and one that hasn't included this because it's relatively new. So inconsistent improvement outcomes, but we do have consistently showing adverse events, including hypertension. And some of those studies actually say they require hospitalization visits. And so the questions I have are, how will this study impact our practice? And then what will the future data look like based on studies like this? So the next time we do a big meta-analysis, if this is included in it and they throw that SPRINT trial in it, I'm wondering what the statistical significance will be of these cardiovascular benefits versus these outcomes that seem to be, or these negative outcomes that seem to be consistent. And so I think for me personally, and this is a question to the group, I think this study will impact my practice for this specific population in that I can have a better discussion with patients in this demographic with the risks and benefit of treatment for hypertension aggressively versus non-aggressively. But looking towards the future to say what, I wonder what it as a composite, what all of this will look like. That's pretty much what I came through with. And that's Olaf from this Halloween. References, and then does anyone have any questions? Okay. So they discussed the sprint trial and they said that the way that they had a couple, are you saying, did they reference the data or did they discuss the differences? Absolutely. Sure. Sure. They absolutely they did comment on that in the discussion, and that there are very much social factors related to diet, lifestyle between our two countries, and one thing I actually commented on is it might be pointing towards the higher cardiovascular disease burden within the United States. But the one takeaway from that I had was in comparing the two studies, there are still positive outcomes. They were just switched and they saw negative outcomes. So I didn't know what to mean by to take away from that data. But they did reference it, and they did specifically in reference to the sprint trial, they did say this is how our methodology differed. We used an app in the sprint trial. The patient pressure taken by a machine without a provider present. We had a trained person take the blood pressure every 2 minutes for 3. So they did compare it really well. So things to look into for that. But,
I think we're going to be towards what everyone knows is pressure reading and your cardiovascular.
Sure.
Higher blood pressure, higher.
Sure. Mm. Yeah. Mm-hmm. Exactly. Yeah. Mm-hmm. Oh, she does. Yeah.
I really think that's exactly what
Mm-hmm.
I'm thinking about.
Mm-hmm. Mm-hmm. Correct. Mm-hmm. Interesting. Mm-hmm. Sure. No, I appreciate that. Thank you. And that's a very good point. Very good point.
Great talk, Dr. Carroll. Good morning, or good afternoon, everyone. I'm Dr. Residoro. I'm one of the other FACTEV fellows, and I'm actually from Naval Hospital Jacksonville, so just from the southeast. And today I was going to present on inpatient ultrasound basics. We do have a POCUS curriculum at our residency, and I use this as a time to create a PowerPoint for senior residents and for faculty to help kind of teach the new interns coming in or just make it accessible for faculty who may have not had POCUS during their residency. So our learning objectives, we're going to review some ultrasound probes and a few techniques for common inpatient medicine ultrasounds and how to interpret these ultrasounds to change management for your patients. So the main three things I'm going to go over is how to determine a volume status, how to get an ejection fraction, and then to review looking for pleural effusions if you need a thoracentesis. So first one, volume status. You get it all the time. You get a presentation from the ER. Could be like an older gentleman. They have a dirty urine. They have like 4 out of 4 surge criteria, but then they get like 500 cc's because they're like, oh, like I don't know if he can handle the fluid. Or you get like a 50-year-old with known like valvular pathology or heart failure, and they've slammed them with fluids because they had most of the surge stuff. If you review the most recent Surviving Sepsis campaign, they've recently changed from like the 30 cc. It's more of a lighter recommendation, just because of the harms that have been caused by fluid overload in such patients. So first thing to look at is which probe do we use? So we use the curvulinear or the abdominal probe. And this probe here is a low frequency probe. So if you remember your good old MCAT days, low frequency creates a longer wavelength. So then it creates a greater penetration. So you get greater depth with this probe. And then just for ultrasound like technique, we try to keep the indicator always on the right side to kind of always get the same kind of images every time. And then you kind of see here, you look for, there's two of the big great vessels. We go in between looking at the liver, using the liver as a window, but looking for big vessels that are either changing with inspiration or pulsatile. So trying to differentiate between your IVC versus your aorta. So usually when you find it, you have the patient sniff, and then you should see a collapsibility in your IVC. And then as I said, you use the liver as a window. So using that soft tissue to kind of look for your IVC. And the measurement that you want for your IVC, you want to do it 2 to 3 centimeters from your IVC right atrium junction, or 1 centimeter away from your IVC hepatic vein junction. And then as you kind of see here, the one on the right is someone that's volume down. Obviously, there's very little fluid going through there. And then on the right, there's not much change at all with inspiration or variation. And I always like to teach my interns nice, easy ways to remember things. So I go 2 by 2, 50%. So 2 centimeters is your normal diameter, or 1.5 to 2.5, but I split the difference, say 2 centimeters. Then we're measuring about 2 to 3 centimeters away from the right atria. So 2 by 2, and then you want a collapsibility, it's about 50% for a normal IVC. So here's an example of a patient being volume down, so very low diameter, and then lots of compression with inspiration. So less than 1.5 centimeters or greater than 50% of that squeeze on inspiration. It suggested that they'd be fluid responsive. I think it was helpful for me because we recently are in low resource settings, especially like during a pandemic, and we have like one cardiologist, the intensive doctor actually told me we're looking more like 60% when the patient is intubated, just because your pulmonary pressures change a little bit when you're ventilated. And here is an example of volume up. So very large diameter and then very minimal change with inspiration. So there's always limitations to ultrasound. So if there's valvular pathologies or some kind of like tamponade, other pathologies you might not necessarily get, but it is a good starting point if you are getting these patients and your attendant's like, do you want to do Lasix now? Do you want to give another bolus? You can have some objective data. And then the correlation for your volume is related to the CVP, which is your central venous pressure, which is related to like your preload. So normal centimeters at 1.5 to 2.5, and a collapse about 50%. Normal CVP is between 8 to 12. So that's kind of why I remember that 2 by 2, 50%. And I got this table from one of our, we do modules. So we have like a sauna site where we learn like point of care ultrasound in our curriculum, and we have opportunities to learn it throughout. Then our next one is ejection fracture. Especially in the Navy, we have some low resource areas where we have one cardiologist and our cardiologist goes on vacation, and then you just have to manage the patient by yourself for a while. Or I was talking to one of the attendings at Fort Belvoir. She was recently at Guam, so she would get an echo and it would take 2 to 3 weeks before she got a read. So definitely can change your management for some of your patients sooner rather than later. And for this one, I like to do, I use the E-point separation, but the first thing you have to do is get the right view. So we're using the parasternal long axis. So we're going to use our cardiac probe or our phased array. So this is it looks like a little bit smaller probe, but it's a higher frequency. So you can kind of get higher resolution pictures with this probe. And typically, so parasternal, so near the sternum. And then you go between the second and third intercostal space to try to get a long axis of your heart. I'm trying to point out here, so this would be a normal parasternal long axis, but you have your left atria, your left ventricle, your mitral valve. You can get actually separation here of your anterior leaflet, your posterior leaflet, and you can even get a little bit of your aortic outflow tract and your aortic valve. And then up top is your right ventricle. And to get the measurement for EF, we use M mode, just like all family med docs do for like heart rate for babies. So you just want to get your M mode cursor on your mitral valve, and we're going to be looking at the anterior leaflet of the mitral valve. So there's 2 images or 2 waves that you'll get. There's an E wave and an A wave. If you remember from cardiac physiology, your E wave is your early diastolic filling, and then your A wave is your little atrial kick. The E wave will tell us how much your atria is filling or your ventricle is filling prior to the atrial kick. And then they did studies all the way back in 1983 to figure out that about 7 is the reliable marker for heart failure, so about an EF of 55% for that study. And I like this because it's one calculation. You get your E wave, and then you can plug it into this formula, and you get an EF that's semi-close. The study down at the bottom was EM residents or EM fellows who were training in POCUS. They were 3 fellows, and then if the patient was randomized to get like a echo, a true TE during their admission, the fellows would scan the patient, do the same kind of studies. They did 80 patients, and they had a sensitivity about 100% for as a presenter mode, but it's not popping up. But it was EF of like less than 30 was shown that they were reliable. Obviously, there's limitations that they're fellows, they're 7 months into a fellowship, and their patients were just the ones in their hospital. They're not necessarily selected out for different kinds of pathologies. I always like to say separating the mountain peaks from the clouds. So you kind of get the good old cloud, which is your IV septum. Then you get the little peaks from your E and your A waves. So just a little distance here, the E wave is the top of that E peak to the IV septum. And then lastly, just review how to get a consolidation. So pleural fusion always kind of gives me a little trauma because as soon as you hear pleural fusion, you'll get the PIM questions about like, what's your Leitz criteria? Is it exudative? Is it transudative? And sometimes it matters, sometimes it doesn't, but especially in trauma settings, we use the abdominal probe again, so low frequency, to kind of look into the depth. On the right side, you have different organs than your left side to make it nice and easy for yourself. Right side, you'll get the image of your liver, your kidney, and then your lung. And then one of the pathognomonic signs of having a pleural fusion is your spine sign. So when you have fluid into the thoracic cavity, you'll actually get shadows that bounce back up from your spine. And that's a little bit of, there's a little sensitivity there of knowing there's actual pleural fusion. And then we switch it over, and then here's normal spine sign and versus no spine sign when you don't have any fluid there. And left side, different organs again. So this time we'll have the spleen and the renal, and then your lung. And this is kind of what you're hoping for as an intern. You like see this ginormous pocket of space that you'll be able to get a thoracentesis out of, but they like to call it the jellyfish sign because it's pretty ominous, and your lung is hanging on by a few loculations there. So just in conclusion, the things I went over are how to get your fluid status. So using your 2x2x50, and then getting your EF, which is an equation using your E point. So, and then your thoracentesis, your pleural fusions, using your spine sign to help kind of look for that to see if someone needs a thoracentesis. And then the literature that I was kind of finding was mostly on EM ultrasound residents. So definitely things in the future as more and more family med docs are getting trained in POCUS or in residency to see how our interreliability is. These are my references. Any questions or concerns?